Okay, good evening, guys. We will have the rest of the complications of pregnancy, and for tonight, we'll start with Hydatidiform mole. Your Hydatidiform mole is sometimes, this is already updated from the 2024 book of Dr. Salustiano. And Hydatidiform mole is sometimes called as Mola Hyda T dosa, sorry, or your gestational tro, trophoblastic disease, okay? Your gestational trophoblastic disease. So in here, there is, okay, so this is, there is a benign neoplasm of the chorion. What is the chorion? The chorion is a product of conception that encapsulates the baby before the amnion, right? So the chorion is the outer part. So the chorion fails to develop into a full-term placenta, and instead it degenerates into a fluid filled vesicle. So let me just give you an idea of what could possibly happen. Okay, so before, okay, so we have here, for example, is the uterus. Okay, um, we have what we call as, of course, sorry for that. This is the one side of the uterus na pahaba tayo. Sige, yun yung fallopian tube na isa. Okay, kapangit naman. Okay, so for example, we will just talk about, just focus on this part. Okay, just focus on this part. So for example, if you had sex, that's insemination. That is the deposition of the sperm cell into the female's vagina. And in 90 seconds, the sperm cell should reach the isthmus of the uterus. And in 5 minutes, it should reach the ambulary portion of the fallopian tube. So in the ambulary portion of the fallopian tube, there is what we call as capacitation. So what would the sperm do in capacitation? The zygote is, or I'm sorry, the ovum is enclosed with two enclosure. Here we have the zona pellucida and the corona radiata. And of course, the sperm cell would what? Release your acrosine and hyaluronidase, okay? So these are the corona radiata and the zona pellucida of the ovum. Okay, zona pellucida of the ovum. Sorry for that one. Zona pellucida of the ovum. What would the sperm do here is it has to dissolve the two layers of the ovum before it could penetrate the ovum. So what would the sperm do is to release your hyaluronidase, okay? Hyaluronidase and your acrosine. So acrosine. So your hyaluronidase and acrosine will dissolve the corona radiata and the zona pellucida, okay? And the zona pellucida, right? So here, again, the hyaluronidase will dissolve the corona radiata and the acrosine will dissolve the corona radiata. And from that time, that's the only time that there will be what we call as fertilization in the ampullary portion of your fallopian tube. So the ovum is now called as the zygote. So if the ovum is now called as the zygote, okay, here, in here, okay, so it will become the zygote, then it will become a blastomere, then from a blastomere, it will become a morula, okay? So let me just write it down. Wait, okay, from a zygote, it will become a blastomere, to a morula, then to a blastocyst or blastocele, okay? So from here, here is the zygote, okay? For example, here's the zygote. It will become a blastomere, then it will become a morula. Then the morula will float inside the uterus for approximately 3 to 4 days, and then it will become a blastocyst. So what will happen to the blastocyst? Okay, it will have what? It will have the trophoblast, okay? It will have the trophoblast, and the trophoblast will be the one to implant the baby into the uterine endometrium, okay? The trophoblast will be the one to implant the baby in the uterine endometrium. So the trophoblast, okay, the trophoblast will give rise now to the products of conception, such as your chorion, your amnion, your placenta, and the umbilical cord. But what happens in hydatidiform mole is the chorion failed to develop and it turned into um, um, vesicle. So there is no pregnancy here. So this is your benign neoplasm of the chorion. Okay, so this is what you call as your hydatidiform mole. Let me just delete everything here. Okay, sorry for that one. Next, for the incidence. Okay, for the incidence, it is common in the Orient of and in people of low socioeconomic status. This is related to low protein intake. Every book that I have read about hydatidiform mole talks about those people who are low in protein intake are more prone to develop H mold. There is also a book saying that, I'm sorry, a book saying that it is more common to Asians because in Asia sometimes there is a problem with the protein intake of this pregnant woman. And then we have here the cause, and again, it's idiopathic. It's very difficult to really to prevent a disease if the cause is unknown, okay? And the risk factors is both, again, this is new, increased and decreased maternal age, okay? Increased and decreased maternal age. And of course, again, low socioeconomic status, history of abortion, and clomiphene or clomid therapy. So these are your clomiphene or clomid therapy. These are ovulatory drugs, okay? These are ovulatory drugs. These are ovulatory drugs. So, guys, before, some of the books would say that history of H mole would lead you to another H mole, but another book is saying that it could be a history of abortion that is leading you to what? To develop an H mole. So if you, for example, had a history of abortion, you have to have prenatal checkups for you to be able to know if your pregnancy is um H mole or a true pregnancy. Okay, so again, history of abortion or the use of clomiphene or clomid. Again, this is an ovulatory drug. This ovulatory drug is being used by women who are subfertile. Okay, subfertile or infertile. Mom, why is it that it's subfertile? Infertility or infertile women are now called your subfertile because we don't want to remove the possibility that they will still get pregnant. Okay, we don't want to remove the possibility that they will still get pregnant. So they are subfertile. So these subfertile women are using clomid therapy or ovulatory drugs for them to be able to ovulate and to conceive a baby. But then again, this is a risk factor to develop H mole. Assessment findings, I will be having a very detailed PowerPoint presentation because I am on updating everything that is written by Flag and Pelletieri and Flag on its on the uh, ninth edition. Okay, so we have here assessment findings. What would you see is a brownish or reddish intermittent profuse bleeding by 12 weeks. So before it is by 14 weeks, but as early as 12 weeks now they found out that H mole will have this bleeding and the characteristic is both brownish or reddish. Okay, it is both a brownish or reddish. Another is we have spontaneous expulsion of molar cyst usually occurs between the 16th to 18th weeks of pregnancy. So we have to understand that it could be vaginal bleeding by 12 weeks and then the expansion of the molar cyst. When we say molar cyst, the chorion that failed to develop will be on the 16th to 18th week of pregnancy. So the bleeding could come first by 12 weeks, but the expulsion of the molar cyst is by 16 to 18 weeks of pregnancy. And of course, one of the big one of the letter B is the big uterus, okay? One of the letter B is the big uterus. When we say that rapid uterine enlargement, it is a very big uterus that is out of proportion, okay? It is out of proportion. When we say it is out of proportion, it is not the same as the normal pregnancy, okay? It is not the normal, same as the normal pregnancy. Sometimes it is, for some books, they would say that when you are already in the 4th month of your H mole, you will have a uterus that is as big as the 9 months, okay? 9 months pregnant uterus, okay? Another one is the symptoms of PIH before 20 weeks. What are the symptoms? We will focus on your HEP. What is your HEP again? Your hypertension. Okay, your hypertension. Let me just use another color. You have your hypertension, edema, and proteinuria. Okay, your hypertension, edema, and proteinuria. And this for PIH, okay, for PIH, it should be occurring after the 20th week of pregnancy. But if you are having now hypertension, edema, and proteinuria before the 20th week, okay, before the 20th week, then you are having an H small instead of a PIH or hypertensive disorders in pregnancy. Ma'am, why is it that we will have excessive nausea and vomiting? Of course, you will have the ECG of 1 to 2 million international units, and your normal HCG is 400,000 international units. So you will have, along with H mode, it is expected that you will have hyperemesis gravidarum also. And of course, you will have a positive pregnancy test because you have your HCG that will give you a positive pregnancy test. And don't forget that it is the trophoblast um that will be secreting human chorionic gonadotropin for you to have a positive pregnancy test. It's coming from the trophoblast, okay? The trophoblast is giving you human chorionic gonadotropin for you to prolong the life of the corpus luteum, because the corpus luteum will act as the placenta for the first 12 weeks of pregnancy. Don't forget that. Okay? No fetal signs, no heart tones, no parts, no movements, kasi typically you don't have a baby inside of you. Just um a snowflake pattern or a molar cyst. And then, of course, you will have abdominal pain because of the very, very large uterus. Okay. Next, we have this one. So the diagnosis, you will see passage of vesicles. Aside from bleeding, there will be vesicles. And the triad symptoms are big uterus, and you will have your vaginal bleeding, and you will have your HCG greater than 1 million. Some books would say 1 to 2 million. And along with this HCG again, since it is known that human chorionic gonadotropin is a contributory factor to vomiting, then it will be leading to hyperemesis gravidarum. When we say hyperemesis gravidarum, it is excessive vomiting during pregnancy, and that is because you have HCG of 1 to 2 million, more than the normal of 400,000. Okay. Aside from that, the uterus, of course, will show you no fetal sac. It is just a snowflake pattern. Okay. Some books would call it your, let me just annotate. Okay, para na kung nasa ibang bansa, guys. Okay, it is very cold in here. A snowflake pattern. Okay, you will have your snowflake pattern in the ultrasound, and of course in the old X-ray, for example, and the flat plate of the abdomen. Then after 15 weeks, or X-rays will be done for us to confirm if there is really a baby, and the ultrasound or the X-ray will not give you anything or any sign that the baby is inside. Okay, so this is the prognosis. Again, if you had an H mole and it comes back, you will have a very high chance of having it again. And if you will have an H mole the second time or the third time around, then you will have a very high tendency of having the choriocarcinoma. When you say choriocarcinoma, the cancer of the chorion, okay, it is the most unwanted. Okay, it is the most unwanted complication of your H mole. Okay, it is the most unwanted complication of H mole. For the treatment, number one is they will do DNC, but again, there is a very high remission of about 80%. And if the mother decides not to have children, and if the mother is above 45 years old, wherein the mother is about to have menopause or the stoppage of mens, then we could decide to have hysterectomy. Actually, hysterectomy is the most or the best management for H mole, because when we remove the uterus, then there is no possibility of the um Hydatidiform mold to come back, and there is no possibility of developing choriocarcinoma. And then HCG titer for 1 to 2 years. Of course, there is no pregnancy dapat. And again, some books would say the woman is not allowed to take combined oral contraceptives. Okay, your combined oral contraceptives combined oral contraceptives because it contains what? Because it contains estrogen. Because it contains estrogen, okay? Because it contains estrogen. And the estrogen will promote the regrowth of the chorionic villi, meaning the estrogen will predispose you to develop choriocarcinoma. Again, there is no pregnancy until the HCG is zero, okay? There is no pregnancy. You are not allowed to get pregnant until the AIDS. Our goal is the HCG will become zero before you are allowed to get pregnant, okay? The HCG should be zero before you are allowed to get pregnant. And along with ACG monitoring for 1 to 2 years, you will have to have your chest X-ray to determine early metastasis. Okay, you will have to have your chest X-ray for the determination of early metastasis. Again, you will have your chest X-ray for the determination of early metastasis. Why is it that the woman is not allowed to take combined oral contraceptives? Because the combined oral contraceptives contains what? Estrogen, and estrogen will promote the regrowth of the chorionic villi. Okay. Another one is medical replacement. Of course, when you are having an operation or hysterectomy or DNC, you will need blood fluid and plasma. And a common board exam question here is your methotrexate. Your methotrexate is the drug of choice for H mole, okay? It is the drug of choice for H mole for us to prevent malignancy or choriocarcinoma or to treat choriocarcinoma. So it's methotrexate. But you have heard, okay, that methotrexate could also be used in placenta increta, wherein the placenta is deeply implanted in the myometrium, in the uterine myometrium, to dissolve the implanted placenta for us to prevent bleeding. And methotrexate is also used for ectopic pregnancy, for unruptured ectopic pregnancy, for us to dissolve the ectopic pregnancy and for us not to be subjecting the patient to have salpingotomy or salpingectomy. So this is your H mole, guys. Okay. For the complications, as what I've mentioned, you will have what? Choriocarcinoma. It is the most dreaded complication. That is why we are wanting for an HCG to become zero first before we allow the mother to get pregnant again. And hemorrhage, okay, the hemorrhage, of course, the bleeding could start as early as 12 weeks. And uterine perforation, meaning the repeated DNC or possibility of hysterectomy, but uterine perforation is related to the conduct of DNC or to the possibility that you will be having dilatation and curettage for them to be able to evacuate all the molar cyst. And of course, since there is uterine perforation, the patient could be having infection. So that is your mola hydatidosa. So what will you tell the mother? You advise bed rest, of course. You have to monitor the vital signs. That is the an independent function. Usually the ginagawa natin, we'll have to monitor blood loss, the molar tissue passage, and the INO of the patient. So we would know how much fluid or blood the patient might need. Okay. And of course, you have to replace all those electrolytes that are lost because of the condition, and you prepare the mother for dilatation and curettage, hysterectomy or removal of the uterus, or hysterotomy. They will just open the uterus, remove the molar cyst, and then tie it again. Okay. So it's hysterectomy, ectomy, removal, otomy, okay, opening. Okay. Hysterectomy, ectomy, removal of the uterus. Okay. Hysterotomy, otomy, opening of the uterus. Okay. It depends on the condition of the mother. Then provide psychological support because the patient might feel that she is having fear because of the possibility of developing cancer or your carcinoma or carcinoma. Sometimes if you are in the province in the Philippines, they would say that you are touched by somebody else. That is why the baby became molar cyst. Okay. This disturbance of self-esteem or in self-esteem for carrying an abnormal pregnancy, they would ask themselves, or they would blame themselves, or they might blame themselves. Why is it that all of the pregnant women are around in the world? Why is it that they had molar pregnancy? Okay, and you have to prepare for discharge and remind them to have the HCG titer, which is very important because this time you have to be very sure that the patient will not be having choriocarcinoma, and that is what we are trying to prevent this time. Okay, we'll have abortion. Abortion is the termination. It is termination of pregnancy before the age of viability, or before the fetus becomes viable, or before the fetus will have the ability to live outside the womb of the mother or extrauterine. So it is the termination, it is defined by WHO, the death of the fetus before 20th week of pregnancy, or it is the termination of pregnancy before the age of viability before the 20 to 24th weeks. Why is it that it is the death of the fetus before 28 weeks? Don't forget that the formation of lung surfactants, don't forget that the formation of lung surfactants starts from the 28th week, okay? The 28th week to 34th week of pregnancy. This is the only time that the baby could live outside the womb of the mother. Okay, there are books saying that there is what we call as early abortion, okay? The book is saying sometimes that there is what we call as early abortion, early abortion, okay? If the abortion is done or happened in the first 12 to 20 weeks of pregnancy, I'm sorry, before the 12 weeks of pregnancy, okay? Before the 12 weeks of pregnancy. Before the 12 weeks of pregnancy. Let me just write. And we also say that it is a late abortion. It is a late abortion. It is a late abortion, okay? It is before, or within 12 weeks, okay, to 20 weeks of pregnancy before. Okay, so we have here late abortion is 12 weeks to 20 weeks. So again, why is it that it is defined as the before 20th week of pregnancy? Because the formation of lung surfactants or surfactants, again, it has to do something with the expansion of the lungs, the ability of the baby to breathe. Okay, the formation of lung surfactant starts from 28th week to 34th week of pregnancy. So it is very important to maintain the baby alive at that very moment. And then, of course, you have here, we call it early abortion before 12 weeks of pregnancy, and we call it late abortion if it happened in between 12 to 20 weeks of pregnancy. And sometimes this is not delivered via normal spontaneous delivery. They deliver it via cesarean section. Wait lang po. Okay, my slide is not responding. Let me just exit it. Okay. Let me just share it again. Something just happened and came up. Maybe my internet connectivity is not that good. And it's opening a double window. Okay. Let me just share it once again, guys. Mhm. Wait. Okay. Sometimes the connectivity and the internet is not good, but please forgive me. Okay. Here, we have it again. We were talking about abortion. Okay. I hope this works now. So, what could be the causes of spontaneous abortion? What could be the causes of spontaneous abortion? The book is saying it's a defective ovum with congenital defects. It is the most common cause. Okay, it is the most common. Okay, so we have here what we call defective ovum. Those ovum or babies with congenital defects, specifically trisomy 16, okay? Trisomy 16 and those with immunologic disorders, and these are the most common cause. Actually, the fetal causes, okay, the fetal causes of this abortion or spontaneous abortion is accounting for 80 to 90%. So if the mother could be a contributory factor or maternal factors are contributory factors to this spontaneous abortion, it could only account for 10%. So it is not, I'm making it clear that it is not the the fault of the mother why the baby became defective or aborted. Okay, so again, defective ovum or congenital defects, the most common cause, and it again this talks about your trisomy 16 or immunologic factors or congenital abnormalities of the newborn. The cause is unknown, and of course maternal factors. Okay, so if the most common cause is defective ovum, the second leading cause is unknown. And if maternal factors again accounts here, it could only be 10% of the overall cause of abortion. And it could be the mother is having a viral infection, malnutrition, or trauma, both. This is new. Trauma is new here. Okay. It was not stated in the book of SIGA before. Trauma, both physical and mental, or the mother might be on severe stress and congenital defects of the reproductive tract or there is an anatomical problem of the mother, and of course incompetent cervix. It is the most common cause of habitual abortion. Okay, later on we will talk about incompetent cervix. It is a cervix that could not hold or cannot hold pregnancy until term. We will talk about it, the different terms of incompetent cervix and how it would cause habitual abortion will be tackled later when we discuss about incompetent cervix. Another is it could be hormonal. It could be decreased in progesterone. Why is it that we're talking about progesterone here? Remember that progesterone is the hormone for pregnancy. It is the one keeping the baby alive. Because we have mentioned before that progesterone keeps the uterus nutritionally abundant with blood for the baby to survive. That is why a decrease in your progesterone could lead to what? To abortion. And another is increased temperature as in febrile conditions of the mother and systematic diseases of the mother, like for example, your diabetes, your thyroid dysfunction, severe anemia, other hazards from the environment that might be related to the job of the mother or the location of the patient, and of course RH incompatibility. Okay, later on we'll talk about RH incompatibility, but RH incompatibility is one also of the most pressing issues when we talk about abortion. So we will have a separate discussion of what is RH incompatibility, of what will happen to the baby. So we have types of abortion. We have spontaneous. So this is new because before we just talk about spontaneous, induced, or therapeutic. When we say spontaneous, it is without medical or mechanical intervention. It could be your septic, your threatened, your inevitable, your or imminent, missed, or habitual, or complete. We will differentiate it later. When we say spontaneous abortion, the book is always saying that the baby is not compatible with life or the baby is not really for you. So another is induced abortion. Okay, induced abortion, the medical or surgical termination of pregnancy before the time of fetal viability with mechanical or medical intervention, or medically induced or criminally induced. So when we say induced, it could be criminally or medically induced. When it is medically induced, we call it sometimes therapeutic. If the doctor would suggest the termination of pregnancy because of, for example, multiple congenital abnormalities of the newborn. So this is a very detailed discussion of what is spontaneous abortion. Its differentiation. You will have number one here, the threatened abortion. Okay, the threatened abortion. What is a threatened abortion? When we say threatened abortion, it is not yet aborted. Okay, because the bleeding is slight, and of course there might be none to mild uterine cramping. Don't forget that the one that is causing the dilatation of the cervix is abdominal cramping or contraction. So if there are no the frequency of contraction or the duration of contraction is not that good, then there is no cervical dilatation. But for the threatened abortion, since there is no cervical dilatation, no tissue passage, and the fever, okay, the patient is having no fever, okay. So what will happen here? You will not hospitalize yet the patient, okay? You will not hospitalize first the patient. Why you will not hospitalize the patient? Because the cervix is closed, okay? Because the cervix is closed, so you may need not to hospitalize the patient. What will you tell the patient to do is to go home and have a bed rest. Okay, the bed rest might be 48 hours, okay? but it doesn't mean that the bed rest is the one that is curing the situation or improving the situation. The bed rest is intended for you to observe and to alleviate the symptoms felt by the patient for us to save the baby. Okay, along with the CBR, okay, a complete bed rest. Okay, complete bed rest. Of course, we should not allow the woman to what? To have sex. Okay, to have sex because the semen of the guys contains what? Prostaglandin. Okay, we should not allow the woman to have what? To have sex because the semen of the guys contains prostaglandin will contract the uterus. Okay, another one is you should not allow the woman to have activities, heavy activities that might aggravate the condition. Another one is inevitable. When we say inevitable, in Tagalog, hindi na mapipigilan, it is imminent. Here, the bleeding and the abdominal cramps are both moderate, but what differentiates it from threatened abortion is we will have an open cervix. So it says here open or closed, but most of the books that I have read, in inevitable abortion, the cervix is already open. And if the cervix is already open, we'll have to deliver the baby. Okay, we will have to deliver the baby. The tissue passage is still none, and a fever still no. Okay, so there's no fever yet. But again, the opening of the cervix makes the situation inevitable. We will have to hospitalize the patient. We will have to hospitalize the patient, and they will have to do NSD, DNC, dilatation and curettage, okay? Dilatation and curettage, or dilatation and evacuation, or dilatation and evacuation, or your MVA. What is MVA? Your MVA, let me just write, okay? Your manual vacuum aspiration, your manual vacuum aspiration. So your DNC, okay, dilatation and curettage, your DNE, dilatation and evacuation, or manual vacuum aspiration are all forms of RASPA in Tagalog, okay? They just do it in different ways or um, techniques, I should say. Another is this one is your complete abortion. Okay, so you have here your complete abortion. Your complete abortion, when you say complete abortion, all of the products of conception is out. All of the products of conception is out. So when all of the products of conception is out, then, okay, then there is no reason for us to hospitalize the patient. Then there is no reason for us to what? To hospitalize the patient because there will be no reason of bleeding. Okay, there will be no reason of bleeding. Okay, there will be no reason of bleeding, and there is no reason for any medical or surgical intervention. So again, complete abortion. Okay, will not have to what? Will not have to hospitalize the patient because there is a complete passage of the products of conception. Because there is a complete passage of the products of conception. Okay, another one is incomplete. In the board exam, incomplete abortion. What is a question coming from here is repeatedly do not give false hopes to the mother that pregnancy will still continue even if there is incomplete or fetal or placental tissue that is coming out. Because when the fetus is out, okay, the pregnancy will not be complete. It could not be saved. So do not give false hopes that the pregnancy will still continue. Okay, the cramps here is severe. So we have to hospitalize the patient for the purpose of dilatation and curettage, dilatation and evacuation, or manual vacuum aspiration. Another one is the missed abortion. When we say missed, the baby is already dead. So the bleeding may be not too severe, or what will you see is no abdominal cramps and no FHT with the ultrasound, no quickening. Okay, the baby is no longer moving and there is no increase in fundic height. Okay, or there is no increase in fundic height. There is no quickening. There is no increase in fundic height, and the cervical dilatation is none. The tissue passages is none, and of course, fever is wala pa, or there's no fever yet. But then again, since it's missed abortion, before they would say that the baby could just go out in 2 weeks time, the dead fetus will just go out in 2 weeks time, so we have to wait. But when we notice that the mother who are admitted in the hospital with the case of missed abortion are battling with mental mental health problems, then we just have to hospitalize the patient and give prostaglandin E, and this prostaglandin E will dilate the cervix. Okay, we call it your dinoprostone. will dilate the cervix and will eventually help us deliver the baby, okay? Dinoprostone. We'll have habitual abortion. In habitual abortion, the most common cause of this is an incompetent cervix, okay? An incompetent cervix, or a cervix that cannot hold pregnancy until term. So the cervix is giving up. The bleeding may be present, and there could be signs of abdominal cramps. And of course, it is usually detected in the threatened or phase of cervical, or, uh, for example, um, it is usually diagnosed after repeated threatened abortion. So they call it 3 to 4 times, okay, and it is due to an incompetent cervix or a cervix that cannot hold pregnancy until term. Septic abortion is because of infection. That is why it is foul. Okay, there is also bleeding and abdominal cramps, and of course, the cervix might be open or closed. But since it is a septic abortion, then we will have to hospitalize the patient for proper management. And if there are two types of spontaneous abortion that you will not hospitalize, is your threatened abortion and your complete abortion. Okay. Next, I love you. So we have here types of induced abortion. We'll have elective. Okay, when we say elective, it is a scheduled or voluntary abortion. Okay, request of a woman, but not for medical reasons. Like for example, mom, is it allowed? In other countries, it is allowed, but for a typical Filipino culture, we are not allowing elective abortion or voluntary abortion, that we are killing the baby without medical reasons. Okay, we will have here therapeutic abortion. The doctor would allow you to have abortion if your baby is or you are in a case of incest or rape, or you have anatomical problems, or your baby or metabolic or mental deformity. So these are the cases wherein doctors would allow your therapeutic abortion, or it is an abortion induced by medical practitioners. Next, we will have another one is criminal abortion. Okay, so we have here the mifepristone and the mifegymiso. It's a mifepristone also. Okay, these are misoprostol tablets. Okay, this misoprostol or cytotec that you are hearing. Cytotec or misoprostol before is an anti-ulcer drug. It should be taken sorry. It should be taken orally. But if you take it orally, it will just prevent ulcer. But if you will put it intravaginally, and that is the time that it is causing the abortion. So we say it medical abortion if we use medication to cause an abortion, like mifegymiso or your mifepristone. These are abortifacients, okay? That would contract the uterus and help us deliver the baby. For a criminal abortion, it is called um criminal abortion if it's unlawful. Okay, it is if it's outside the medical facility, and it may lead to what, to complications of to the mother. Okay, so medical abortion if we use mifegymiso, mifepristone, cytotec, but it is considered a criminal abortion if it's done outside the medical facility. It leads to the death of the mother, or another condition that would complicate that abortion, or it is unlawful because it is done by artificial means. So that's criminal abortion. Signs of abortion. In every abortion, you will have vaginal bleeding or spotting that may be mild to severe. And of course, with vaginal bleeding, you have your uterine cramping or abdominal cramps or contraction. And this contraction is the one that is opening the cervix. Okay, passage of tissues or products of conception, and signs related to blood loss or shock. So there is a passage of tissues. With the passage of tissues, when we see the passage of tissues, we call it as your products of conception. It may be the baby, the umbilical cord, the placenta, the chorion, and the amnion. So you have your products of conception, you have the baby, the placenta, the umbilical cord, your chorion, and amnion. So when there is a tissue coming down there, you have to know, or you have to be familiar of what is that. Okay, so you would know what type of abortion the mother is suffering from. So you would know what to do. Okay, specifically. Okay. So prevention of abortion, in general, you have to eat healthy, and you have to exercise to decrease the stress, because stress or mental trauma is one of the causes, and avoiding smoking because it could lead to vasoconstriction. drugs and alcohol are always causes of these complications of pregnancy, limiting caffeine. Since caffeine is not nutritious, it will just give you the feeling of fulfillment, but it is not nutritious. Controlling stress, okay, and healthy weight. So this could be the ways on how to prevent abortion. Okay. So what will be the medical management? Okay, medical termination. For early abortion, you will have to use antiprogestin, your mifepristone, you will have to use your methotrexate and misoprostol for you to be able to evacuate the baby. And if it's the second trimester, then you will have to have oxytocin and prostaglandin or high doses of this, because methotrexate, mifepristone, or misoprostol will never be enough to deliver the baby at this time. For surgery, they will use a vacuum aspirator, so your manual vacuum aspiration or your laminaria. Your laminaria is what you have here in the figure. So the laminaria is properly inserted in the cervical os here, and of course, it will be expanding. So later on, it will cause cervical dilatation. Ma'am, why do we have to use antibiotics? Because there are septic abortions. You'll have to replace whatever is lost, so you will need plasma and blood. And for habitual abortion, later on, we will talk about cerclage. We will have your McDonald and your Shirudkar and your transabdominal cerclage. And of course, blood tests for the possibility that the abortion is caused by RH incompatibility. So this ectopic pregnancy and the rest and hyperemesis gravidarum will be recorded in a separate video for us to be able to discuss it properly. Thank you so much and good day.